I want to transition to our welcoming our plenary speakers who are going to be presenting on Bridging Practices and Communities, a week in the life of a practice facilitator in rural Colorado. So maybe getting at Samantha's question, this will be a peek kind of beneath or behind the curtains as to what a facilitator really does, at least in one setting. So Christin, who's with us today, is a practice facilitator and a community research liaison for the High Plains Research Network. She joined the network in 2006 and works with primary care clinics and communities throughout the 9 counties of northeastern Colorado. She has over 9 years of facilitation experience working with practices on a broad range of transformation programs, including the Patient-Centered Medical Home, Comprehensive Primary Care Plus, the State Innovation Model, and many others, some of which you heard Stephanie mention when she was talking about her role in Colorado. Let's see. She helps implement, maintain, and evaluate research studies covering topics such as colon cancer, asthma, home blood pressure management, childhood obesity, opioid use disorder, cancer survivorship, blah, blah. You kind of the normal for a facilitator, right? In many settings. Christin's also joined by Linda Zittleman. And Linda doesn't have a blanket on, but she gave a plenary yesterday in a blanket, as Jolt mentioned up front here. Linda's a senior instructor at the University of Colorado in the School of Medicine. She's co-director of that High Plains Research Network and staff for the Colorado Clinical and Translational Sciences Institute. She has extensive experience working with rural practices and communities on a range of studies, and helping design and manage multi-site, multi-method research projects. Her work aims to provide support for rural primary care through research and practice transformation and to create connections between clinical practice, behavioral health, public health, and others in rural communities. Linda also coordinates the High Plains Research Network Community Advisory Council, which is composed of local farmers, ranchers, school teachers, and others that participate in all aspects of the network's work. So I'd like to welcome our 2 plenary speakers. Let's give them a warm round of applause and lots of nods and smiles as they present today.
Thank you. Good morning, everyone. As Melinda said, I'm Linda Zittleman, and I am very happy to be here this morning, and I want to take a moment to thank Melinda and Jolt for this opportunity for us to be here to talk with you this morning. I'm very glad to be here with my colleague, Christin Sutter. And as Melinda was describing, Christin is a practice facilitator, she's a regional connector, she's a research assistant, she's a member of the Community Advisory Council. I'm sure lots of you can relate to having lots of titles and different hats. And she's been with the High Plains Research Network for 13 years. So with the theme of this year of bridging practices and communities, what we want to do this morning is really share a story with you of what this looks like for us in Eastern Colorado and in the context of the High Plains Research Network. So to do this, Christin and I are going to tag team this talk. We're going to start, though, by describing where we're from, so you have some context of where this story is going to take place. Then we're going to take a trip through Eastern Colorado and experience a snapshot of Christin's life as a practice facilitator in a rural community. She will walk us through a week in the life of being a rural practice facilitator. So through this, we aim to share with you some of the strategies that we use to help bridge what we're doing in the practices with the broader community context. And I hope, and I'm sure, that some of these will really resonate with you. And you'll say, yeah, I do that too. But we're also hoping that there might be a new idea that pops up and something that you can take away with you back to where you're from. So before we start our week, let's get a sense of where we are going to be, and that's in the High Plains Research Network. So I'm going to start a little academically here, and I apologize for that. How many of you were at the Practice-Based Research Network conference that was held here Monday and Tuesday? Okay, great. I was too. So These boxes might be familiar to some of you. They're called the Carr White boxes, but I'm going to let you Google Carr White so you can learn more about him on your own. The High Plains Research Network is a practice-based research network, and I wanted to show these boxes because they show an important concept of the way we approach our work and why we think it's important to bridge what we're doing in the practices with the broader community. How many of you here have seen this before? Oh, a lot more than I thought. Yay. Okay, I still will describe it though. So what these boxes show is really the distinction between where folks live and spend most of their time and where most research occurs. So hypothetically, if we have a population of about 1,000 people, that community in that big, large box, most traditional research occurs in that teeny tiny itsy bitsy little box in the corner where there's one person who has a health condition and will seek care in an academic or medical center. That's where a lot of research happens. It's very important research, but it's a very controlled setting, and oftentimes what discoveries come from that don't just automatically translate to what's happening in the practice or reaching the people in the broader community. So a practice-based research network like High Plains aims to take that work to that box where there's about 250 folks, where folks are seeking care. And it's often from their primary care provider, and especially in rural communities, that's especially true. But we all know that people don't live at their clinic. They don't live in that box, they live in that broader box. And that's why our approach is to try to engage and make connections with folks outside the walls of the practice to help inform the work we do, to participate in the work we do, at minimum so they're more even aware of the work that's being done in their backyard. How many folks here are from a rural region? Okay, well, that's a lot. Great. Okay, so this is a map of Colorado. High Plains Research Network covers 16 counties. They're rural and frontier counties. It's the entire eastern third of the state of Colorado. And in that region are about 53 primary care practices. There are 16 hospitals. About 150,000 people live there. Yes, there are more cattle than people in that region. And Christin works in the 9 counties that are in this northeast corner. It's more than a corner. So, how many folks have been to Colorado before? Wow, holy cow. I suspect for many of you, your exposure to eastern Colorado looked something like this when you're coming in for landing, flying into Denver International Airport. And when you look down, you see a mix of circles that are from center pivot irrigation systems and squares from dryland farms. But once you get on the ground, you'll be in a space that is suffering from a lot of health issues. And I bet many of you can relate to what we're seeing here in eastern Colorado. About a third of high school students in this region report feeling so sad or hopeless that they stop doing usual activities. Over the past decade, we've had a 300% increase in our drug overdose death rate, and most of that is due to opioid use. And almost all of the counties are in the bottom half of the state averages when it comes to cardiovascular health. And I point those out because we'll hear more about some of the work Christin's doing that relates to these issues. But when you're on the ground, you'll also see this. You'll see a highly agricultural region. Farming and ranching are very big in this part of the state. You might also attend a Friday night football game, and it might be a full 11-man team. It might be an 8-man team. It might even be a 6-man team. You will find communities that are very proud of what they can accomplish when they work together. And you might even meet the lucky soul whose office is here on the edge of this field. I actually took that picture, and I thought maybe we should move our High Plains headquarters out there. And we got some wind, folks. It gets a little windy out there. This is actually Kristin's previous home on an exceptionally windy day. A little tumbleweed problem. It's not photoshopped. We always get asked that. And I'm going to let you ask her during our Q&A, what did you do about that? So I'm going to give you a minute to take this one in. I like to call this image good intentions. So like these firefighters, the research team back on campus, and this includes people like me, and I'm sure when you think about your organization, you can think of someone who falls into this bucket, where we have equipment, we have skills, we have good intentions about wanting to help people in communities and practices with a variety of health problems like I described earlier. But sometimes we miss our mark. So our question constantly is, how can we do work that's relevant to and responsive to the needs of practices and communities in Eastern Colorado? How do we bridge communities and practices? And I want to introduce this group to you because you will meet them more later in the week. One strategy that we use is having an active community advisory council. So the council consists of local free-range humans, as they call themselves. That's what they name themselves. They're farmers and ranchers, teachers, students, dental hygienists, folks who have experience working in and living in Eastern Colorado. This group includes Christin, and you'll hear more about them later. Okay, so over the years, I know I've been saying the word research a lot, and I'm very aware that I'm at the Practice Facilitation Conference. So I want to talk a little bit about how this has come to be in the work that we do, where we have more facilitation presence. So over the years, you can see here that the High Plains Research Network has conducted projects on a host of different health topics: asthma management, home blood pressure management, treatment for opioid use disorder, colon cancer prevention, the prevalence of underinsurance in our rural communities. But several years ago, we recognized that a lot of the projects and programs we were doing in the practices had elements of practice facilitation in them. We were also seeing that practices were being asked to, or encouraged in some cases, or even mandated in some cases, to do certain things that overlapped with our programs, such as providing team-based care, figuring how you're going to bill for a service, where do you store data, and how do you pull out data that's meaningful and useful. So this overlap, combined with the relationships that we've developed over the years and the presence in the practices, it just made it a natural step for us to explicitly enhance our staff's training and skills in practice facilitation, and to work with the practices on some specific transformation projects. So as Melinda mentioned, Kristin's worked on patient-centered medical home, TCPI. We're currently working on SBIRT, the screening, brief intervention, and referral to treatment, the state innovation model, projects like that. TCPI is Transforming Clinical Practice Initiative. Thank you. Okay, so that's where we're at. Oops, I don't want to steal your thunder. So now you've had a sense of where you're going to spend the week. And as you can see, Kristin's currently involved with a lot of different projects. I do want to say, though, we're not going to focus on the details of the projects. That's not what we want to do here. But we will try to give you enough information about them so you have some context as to what Kristin's doing. I also want to warn you that we don't have a lot of slides. And I know that might make some of you uncomfortable. Some of you might love it. I'm not sure, but I hope it's okay. What we want you to do is sit back, relax, and spend a week in the life with Christin and see how she works to bridge practices and communities. So with that, let's learn a little bit more about Christin and start our week.
Well, good morning, everyone. I am Christin Sutter, and I'm really grateful for the opportunity to be here with you all this morning. As Linda mentioned, I've been working with her in the High Plains Research Network for 13 years. And I think it was about 8 years ago that I added the practice facilitator name to my list of titles. So I work with the clinics, the hospitals, and communities in that region that you saw on the map. But I don't just work out there, I live in those communities as well. I was raised in this area on a farm that is still run by my grandpa, my dad, and my brothers, and they farm corn, millet, and wheat. My husband and I now raise our 3 teenage daughters. Yes, 3 teenage daughters. Yes, so that makes even talking in front of people seem like not a big deal, right? And we live in the small town of Merino. Merino has a population of about 300 people, where my husband's the head football coach, I'm the head volleyball coach, because it takes everybody doing everything to make our little communities work. And this entire 9-county region looks like towns like Merino. We're just scattered throughout the region, agricultural communities. It's about 16,000 square miles that I work with as a practice facilitator. We have 2 super Walmarts. And I tell you this because we all measure how rural we are by how far we are from the Walmart. And so understanding this agricultural lifestyle is necessary for our communities. Many people live more than 30 miles from the closest town. So we know that distance and weather, they make a big difference in our lifestyle. So when we work in a clinic and start talking about things like getting people in for regularly scheduled blood pressure checks, that can be a challenge. And it's something we need to look at a little bit differently. We also we're not going to get farmers to town during harvest, calving season, and planting season unless a tractor breaks down and they need a part. So those are important things for us to understand as we facilitate and work in these communities. It's a great way of life, though. There's a ton of strength and pride in our communities. And hiring local people like myself has really helped us to keep a pulse on the finger of those communities, finger on the pulse, sorry about that. And it helps us to understand some of these unique challenges. On the flip side, it also helps to have a local person reassuring our community members, in addition to our community advisory council, that the big city folks coming into our community, that it's okay. There's a lot that we can learn and that we can share with each other. So it's really nice to have local people involved. So we thought it would be fun to just show you what a week in Eastern Colorado can look like. One of the best parts of my job, and I'm sure many of you, is that no day or week looks like the one before. So we're going to start on Monday morning, and thankfully we've had a nice restful weekend because it's going to be a busy week ahead of us. So this morning, we're going to head to a meeting at a practice that's participating in the State Innovation Model, or SIM. And the Colorado State Innovation Model aims to help primary care practices integrate behavioral health and physical health in primary care settings and learn how to utilize alternative payment models. So this practice is located close to where I live, so there's no travel time today. It's a federally qualified health center, and they have been working to hire a behavioral health person on site for more than 2 years. They're flexible about the type of provider they want to hire. What they know is that this person needs to be bilingual. So that's really their main requirement. They're super frustrated. They've partnered with the Community Behavioral Health Center. They're working to hire this person jointly. They've had several people apply, but in the end, they end up accepting positions near Denver or the larger cities where there's a little better pay, more amenities, they're closer to the mountains and all the fun things there. And so as a result, I've been trying to creatively, as I'm sure many facilitators can relate to, try to help them move forward as they struggle to hire this position that they don't seem to be able to, they're not able to compete for hiring this person. So we've been meeting and brainstorming about other things that we can do in the clinic to improve whole person care, utilizes the resources we have in our community. And one of the providers started talking about some challenges that she'd been having with some of the young children and families that she'd seen over the past couple months. These children were coming in and they'd been having some behavior and attention issues at school. And each of these cases, she didn't want to make her decision for treatment based on that visit with the family alone. She wanted to be able to talk to the teachers at the school, hear a little bit more about what was going on, and in some cases, she needed some additional evaluation and assessment. As you can imagine, trying to connect a provider with a teacher who has more busy schedules than those two people, right? And trying to connect them, she was spending a ton of time on the phone trying to connect with the teachers at the school. And she had found at Children's Hospital in Denver where she could refer these families up to get the assessments she was looking for. And that's about a 2-hour drive from this clinic. And the families were pretty resistant, as you can imagine. That's a lot of time off of work. In some cases, transportation was an issue. And so as we talked about this, we felt like this was an area where we could try to connect with some local resources and try to improve the whole person care as we're in this hiring stall. So I suggested that we reach out to the school psychologist. She and I have worked together on other programs, and she's always interested in what's happening in the primary care practices. So she's joining us for this meeting today. So as we sit down, the provider starts to recount her story and the challenges that she's been having with these families. And so we pull out a piece of paper, and they start exchanging fax numbers. And pretty soon, they take out a piece of paper, and we've actually drawn out a fax cover sheet that's going to serve a lot of purposes. And it's a direct line to the psychologist at the school. The cover sheet is going to protect patient privacy, but it also has a way to flag the psychologist that this is from the provider. So we can avoid those long phone call waits and the phone tag back and forth. The psychologist goes on to tell the provider these assessments she's been looking for have already been done by the school district in almost every case. And the clinic team is just shocked that this is happening in their town. It's right here, and they did not know that it was available to them. We've got some work to do in future meetings to figure out the release of information and all of those pieces, but the psychologist is pretty confident that we can get that information to the practice. I find myself relieved that the clinic has been able to make this connection with this other local resource. It's frustrating that they've been working independent of each other for so long, but hopefully this can help improve the efficiency for each of them, as well as improve that whole person care for these children and their families. This isn't uncommon. Oftentimes, I find when I work with primary care practices, they're unaware of the services that are offered, even in our local communities. And that's not because the other organizations haven't tried to reach out. They bring over their brochures and their pamphlets, but they end up stored in the drawer. And not because practices don't want to use them. They're busy, and we all know this. And so as a facilitator, I try really hard to get out into the community and know what those services are, so that when they find things that they're missing, I can try to connect with what we do have, even in our small rural communities. So that is Monday for you. We're going to fly forward to Tuesday. It's Tuesday afternoon, and I am headed to a meeting in Yuma. Yuma is about an hour from my house, and we are headed to meet with a local community organization called Baby Bear Hugs. Baby Bear Hugs is a nonprofit community organization, and they provide parenting education, resources, and support through home visits to new mothers and their children. And they work with families that have children from newborns to about 3 years old. Our Community Advisory Council that Linda had mentioned earlier has recently worked in partnership with the local school district and a local family physician to develop a program and materials to promote mental health, starting with new parents and their babies. And so when we learned about baby bear hugs, this seemed like the perfect partnership to try to pilot test this program in our communities. So today I'm going to meet with the Baby Bear Hugs staff to discuss how we can add these materials to the flow of their visits with families. So 20 home visitors are here at this meeting with us. They serve the same 9 counties that I work with, and they love the materials, some of which are shown here. So we give them a children's book. There's a handout on how to promote bonding with the mother and child as they're reading, a bib and a onesie. We have a coloring book and resources for the mom or the caregiver, as well as a refrigerator magnet that has mental health tips and tricks for the family. So we discuss not only how to go through these resources with the families, but also the evaluation process. How can we collect meaningful data from this that'll determine how the parents respond and use these materials? We want to learn from these families and figure out how much value this resource actually brings to them. Because going forward, our next step then is we want to think of how we can involve primary care in this process and close that loop. So we want this data to help us understand how this is helping families.
All right. So 2 days down, two days into this week, and we can already see 2 examples of how, for this facilitation work, sometimes the projects are based in the practice, and we reach out and try to engage other members in the community. Who else needs to be at the table to make this work? Sometimes the source of the work is in the community, and the question is, how do we engage the primary care practices or others who might need to be at the table from the healthcare community. So get a good night's sleep tonight. It's Tuesday night, because tomorrow is going to a practice to deliver both training and facilitation work for a project that's called It Matters. And I'm going to tell you a little bit about that project so this makes a little more sense to you. It Matters is a project funded by the Agency for Healthcare Research and Quality. Thank you, Bob. And the purpose of it is to increase access to treatment in rural communities, working with rural primary care practices. So working to increase all of the practices' understanding of what opioid use disorder is and medication-assisted treatment with buprenorphine. It has multiple components, actually. Just to give you a little overview, this project actually has a community intervention. That was developed by the High Plains Research Network Community Advisory Council in partnership with pharmacists, public health, people from the faith community, a very well-rounded local group, and that campaign's called Have You Met Matt? And you'll hear more about that later. We do support training providers to complete that special training they need to do in order to prescribe buprenorphine for opioid use disorder. But what we're going to focus on tomorrow is this component for practice team training. And this curriculum was developed by the research team, experts in MAT, community members, and practice facilitators like Christin. Christin was on the team that helped develop this curriculum that we're now using in the practice. This project has really required Christin to build on her practice facilitation and her researcher skills. So let's hear how she combines education with facilitation to address the opioid epidemic.
So it's Wednesday morning and we're packing the car. This time we're headed to Holyoke. It's about an hour-and-a-half drive both ways. And the training today is going to be that all-staff training. So there will be about 20 people in attendance, everybody from providers, nursing staff, front office. We want the whole team to get the same base knowledge of what medication-assisted treatment, or MAT, is. We want the team to understand what opioid use disorder is And most importantly, we want them to see how they can deliver medication-assisted treatment as a team in their practice. So we're working with practices throughout the whole readiness spectrum, and we're just trying to meet them where they're at and give them information to help them take next steps. So the program includes 5 sessions, and I go out about once a month to the practices to deliver these sessions. This program requires me to deliver a lot of information about opioid use disorder and medication-assisted treatment. So at my earlier visits, we trained the team on things like statistics and the epidemiology of opioid use disorder. We talked about what opioids are, described the neurobiology of addiction, and the effectiveness of buprenorphine. But the training also includes built-in facilitation time. This is critical time to help the practice start to take those first steps. They start to identify members of their team that have a passion for this topic and a passion for helping people who have opioid use disorder. They start to look at the culture of their clinic and think about things like, what are they going to do when a patient relapses or when they have a failed urine screen? And they start to use those conversations to build their treatment agreement for these patients. At my last visit, we discussed the steps and documents that they needed to prepare for the patient for treatment, and we started to map out some workflows. I used this facilitator support guide that we have here on the screen that we developed for this project, and it's been very interesting to watch the practices progress through this, honestly, to work through some of their own concerns and biases around this topic. After the first session at this practice, there was a person from the front desk who raises her hand and she says, this has been so helpful for me. I didn't even know what opioid use disorder was. I had no idea it was connected to heroin. And this explains why sometimes people are so cranky about their prescriptions and they're so mad at me on the phone. Just reiterating why it's so important to have that whole practice team as a part of these trainings. At this specific training today, we're going to walk through the specific steps of medication-assisted treatment. We're going to talk about the induction phase, stabilization, and maintenance. We're going to describe the symptoms that somebody would be going through as they're inducted into medication-assisted treatment. And I also work with the practice to identify who on their team can do some of these steps. There's so much that the team can do in this, not just the provider. And then we also talk about some information that I have for the clinic from a recent meeting that I had with a local pharmacist. The pharmacy is set up that they can drop off old prescription pain pills at any time, but they wanted to do something to increase awareness in the community, so they also scheduled 2 safe drop days. And they want the clinic to pass this information out to their patients. And so we talk through how they're going to get that information out. This project has really been a new challenge for me as a facilitator. It required me to learn a large amount of information on a very specific, complex, and stigmatized medical subject, and then deliver this training to the practice team. My comfort obviously lies in helping them implement this work, develop workflows, and manage the change as a team. And at first, it was a really uncomfortable shift for me to be delivering this kind of information. But what I quickly realized is my prior work as a facilitator uniquely prepared me to deliver this training. I was a part of the team that created the curriculum, and over time, that facilitation background helped us to realize we needed to shorten the education piece a little bit and allow some time at the end for discussion to try to identify action steps so that they can start to engage a little bit sooner in what to do on this work. So we tried to make these small steps each time so that they were poised to act as soon as the training was complete. So the other key element to this project is the work that the Community Advisory Council has laid out in our communities. So we've developed materials to educate community members on what medication-assisted treatment is and opioid use disorder. And the goal is we want these materials to encourage community members to ask their local primary care provider about the treatment options. Or if they know someone else who needs help, to be able to connect them with local providers. So this component is called Have You Met Matt? So do you get it? Matt, M-A-T. And so when I'm starting off with a practice with team training, I always outline these three components. There's the provider training, the team training that I just talked about with you, and then there's this community piece as well. Because we want the practices to understand that the work they're doing on this project is also being promoted in the community. And those suffering from opioid use disorder will know that they can find help locally. So as I leave the clinic, I am encouraged by the great questions and comments that the practice has made following the session. It's clear that they feel very connected to this topic, and they're appreciative to have received the training together. But something that has come up at the end of this session, as it does at almost every other clinic, is how are other clinics doing this? What are they doing that works for their schedule and for their patients? How do they fit it into their day? So we find that ourselves working to not only connect the patients from the community with the practice, but also connecting clinics with one another so that they can find the best ways to implement this successfully for their patients. So that was Wednesday. We're moving on to Thursday. And today we're just going to start out with a phone call with Linda. That's pretty relaxing. So we're going to get our coffee as we recap the week and kind of catch up on what's been happening on these projects. Linda and I talk about the meeting at the FQHC and the involvement of the school psychologist, and kind of visit about it wouldn't be a bad idea for me to stop by the school and make sure that on their side the communication channel is working as well. We also talk about me scheduling a meeting with our regional mental health center to share some of the ideas and concerns that practices have around the MAT implementation. So that's our quick catch up. And we're going to zoom ahead to the end of the day on Thursday. So it's just before 5 o'clock, and I'm headed to Sterling. The metropolis of eastern Colorado has about 14,000 people in the town, very much the largest town in the region. It's about 15 minutes from where I live. So as the Walmarts go, I'm not very rural. I'm presenting the It Matters program to the local Rotary Club. So for those of you who aren't familiar, the Rotary Club is a service organization with various community and business representatives. And I know that this group is eager to learn more about the work that's happening in our region. Years ago, I got to meet one of their leaders. They wanted to know a lot more about what we were doing with the High Plains Research Network. So now they invite me to present once or twice a year to update everybody on the projects that we're doing. This is a great opportunity to connect with even more community members and engage them with what we're doing and what's going on. So I give them an update on what we're doing around opioid use disorder, medication-assisted treatment. I'm very excited to let them know that more and more practices in the region are preparing to provide this service to our community members to help alleviate the opioid crisis. The group is very engaged. I have a lot of questions. And there's a pharmacist in attendance who shares some of the work that she's doing on opioid use, and she wants to find ways for us to work together.
So I just want to point out that in addition to reaching out and being present in some of the local organizations in the community, Christin's position includes going on the local radio station and talking about some of the work that's being done. She's also been on the regional national public radio station, and she helps to do other things like writing articles for the local newspapers. So that connection with the media is part of her work. Okay, so we're headed into the end of the week. How are we doing? We're hanging in there. It's a busy week. Christin is now going to do some work with a practice and a new partner on a home blood pressure management program called Just Check It. And I want to give you just a little bit of information about what Just Check It's all about so you understand what Christin's doing. Just Check It has historically been a very practice-based project, working to reduce and help the community members and patients in Eastern Colorado control their hypertension, because as we remember from before, cardiovascular health we're not doing so great in Eastern Colorado. What happens with Just Check It is that a patient receives a blood pressure monitor and a patient toolkit, and they're asked to report their home blood pressure to a system that feeds that information back to the practice. Christin, over the years, has helped practice teams learn about hypertension, the ins and outs of this program. She helps develop workflows, determine where those reports will be stored, how will that information get to the clinician. I think this probably sounds very familiar to a lot of you of how do we get this to work in the practice. We realized, though, that recently we were missing a really important voice in this program, and that there was an important health partner in the community that we needed to bring into play here. So let's catch up with Christin at this meeting. And are we on Friday? We're on Friday. Woohoo!
It's Friday. And today we're back in Sterling, and I'm with Penny. Penny is a health navigator at the public health department. And we're working on this Just Check It home blood pressure program. We're implementing this in the clinics and in the public health department. And so I'm working to bridge this communication between those two entities and try to strengthen those relationships. It's really important that they're on the same page and have a unified message as they're delivering this to patients participating in the program. So today, Penny and I go over the workflows that are happening on the practice side so that she can understand from their perspective what this looks like. And then we start to look at their workflows and how this is going for them enrolling patients. What's supposed to happen is that the patient gets referred over from the clinic, and this is a great partnership because the public health department then will teach the patient how to use the blood pressure cuff. They'll enroll them in the program. They have that extra time that the clinic doesn't have. And so it was all set up and great, but now all of a sudden, nobody's calling to schedule appointments. They're just getting patients showing up at the health department all day long saying, oh, I'm ready for my blood pressure cuff. And so this has proved to be a little bit of a burden to the health department staff to make sure they've got somebody trained on site. And so kind of brainstorm how we can solve this so that we're meeting that patient need from the practice side, but also in a way that can work for their staff. So we develop some workflows that we hope will continue to work. And then our next step, of course, will be going out to engage with the practice and ensure that that communication on their side, they're going to send those referrals over appropriately. So after our meeting, Penny and I are going to head over to a practice that wants to implement the program. And together we'll give an overview, and presenting together is a great way to help bridge this, to get the practice engaged with more of what's happening out in the community. So you made it. You think you're done, but you're not, because we have to do something on Saturday too. It's the end of the week and we're so tired. And so thankfully, we get to do one of my absolute favorite things. Once a quarter, we have a meeting with our High Plains Research Network Community Advisory Council. This is the group of free-range humans Linda was talking about earlier, and they volunteer their time to inform our research and ensure that it's locally relevant and meaningful. We usually meet on a weekend. It's an all-day meeting, and it's at a church or a community organization building in Eastern Colorado. So I drive the hour back to Yuma. We were there earlier in the week for our all-day meeting. And at this meeting, we recap the projects, most of what we talked about during this week. And we also spend some time with a guest researcher who gives us some information on a new program idea. So the group listens to the new idea and considers its importance in our communities. The Community Advisory Council continually reminds Linda and all of us just how important it is to engage not only the practice teams, but the local community members as well. So how do we pull together existing resources, organizations, clinics, providers, businesses, so that we can serve our communities in the best way possible? I get to hold this really fun, unique position on the CAC because I am an employee of the university and work as a facilitator, but I'm also a community member. I'm a coach, I'm a parent, I'm a neighbor to people in this area. So I kind of get to live in both worlds a little bit. So to end our meeting on this day, we discuss how the Have You Met Matt community intervention for It Matters project is going. We've distributed all these materials you see up here throughout the entire 16-county region of Eastern Colorado. We have local bars and restaurants that are distributing our coasters. The pharmacies and libraries are distributing the inserts. And the posters are hung everywhere from schools to banks to grocery stores. And our hope is that this knowledge will help drive patients and community members to the practices to ask for help, in this case about medication-assisted treatment. I've been one of the main team members distributing these materials around Eastern Colorado, and being involved in this arm of the program really helps me keep a foot planted both in the practice and in the community. So, as always, I leave these meetings feeling extremely motivated. It's hard not to, with this group of people that shows up and continues to volunteer their time and remind us just how important this work is that we're doing in our clinics and communities. So now my job is to carry their energy with me as I continue to share their messages throughout Eastern Colorado.
All right. We do stop on Saturday. There's no Sunday, but whew, that was a whirlwind of a week for Christin. She's glad to be home Saturday evening and enjoying this beautiful moonrise in Eastern Colorado. Are all of her weeks like this? No, but I know that sometimes it feels like it, and I'm sure many of you can relate to that feeling of, holy cow, I have weeks like that all the time. So now that you've spent time with Christin in Eastern Colorado, we want to just reflect on how do we bridge communities and practices. This is what it looks like in Eastern Colorado and in the context of the High Plains Research Network. Let's just think about some of the things that were revealed during this week. How do we try to make this bridge happen and take facilitation outside of just the practice walls? What that looks like a lot for us is just having a facilitator who is outside the practice walls. As an organization, we try to hire local talent. And as I was preparing for this, I thought, that's interesting when we say local. We use the word local a lot. We want local this, local that, local community members. Think about what local means to you and where you're from. I don't think it's just geography, because as you can see, Christin works in a 9-county region. So what makes her local in your work? What makes you local or your team local compared to other people on the team? I'm not local. I live in Denver. I love Eastern Colorado, but I'm not from there. So think about what local talent might mean in your world. Make connections. Meet people at those other organizations with whom your practices need to work. Physically bring them together. That school counselor and the provider Christin met with on Monday work 2 miles apart, but she had to literally bring them together so that they could have those conversations. Use your love and appreciation for data. I know you all love data. Take that everywhere. Christin had to really talk through with the local community organization, Baby Bear Hugs, about how are you going to measure the impact of what you're doing, and how do we connect the practices, and how do we use data to do that? Windshield time is a biggie. I don't think it matters if you're in rural or urban. It certainly applies to, the concept of windshield time applies to rural communities. You gotta get in your car and drive. But I think that concept applies no matter where you are. It's about getting out from the comfort of your office or wherever your comfort zone is. For the folks in the room who are like me, who are program directors and leaders, supervising and trying to enhance the team's skill set and professional development, think about how do you use those practice facilitation skills that are on your team to influence and help develop programs and projects. As we saw with the Matters curriculum, Christin's fingerprint is all over that, and it is much better for it. She brought that perspective to the table that other folks at the table didn't have. Get to know your community organizations and media outlets. Tell them about what you're doing and the partners that you're working with and why it matters for your local region and your local community. Establish and nurture relationships with supporting partners. Who are the pennies, Penny from the health department, who are the pennies in your world? And what can we do to support those? Maybe they're with community health centers, faith-based communities, youth groups, all sorts of potential ways to connect with others in the community and engage with those folks. I don't know, well, I do know that not everybody here has probably a community advisory council type group like Christin has had the opportunity to work with. But think about, what could that look like for me? What can I join and influence? So I know that this has been set in a very rural context, but I don't think that these things really matter if you're in rural or urban. I think they apply no matter where you are. For us, we aim to bridge practices and community largely by being present. Present in the practices, we're present in the community. The role of the facilitator here is to remove those barriers, and there are a lot of ways you can do that, to remove those barriers between the practice and the broader community. Years ago, the High Plains Research Network Community Advisory Council actually did a project where they learned all about patient-centered medical home. That was an interesting one. But they thought it was important because they were realizing that, gosh, our local practices, they're doing all this work kind of behind the scenes, but I think maybe they thought the community should know a little bit more about it. And at the end of the day, what they took away from learning about patient-centered medical home and all the jargon that comes with it was this: that medical home is relationship. Now we're trying to move from the medical home to the medical community. And for us, the practice facilitator can bridge those practices and communities by really being an ambassador to both. Doing some windshield time, seeing opportunities to apply those skills in different settings, and building relationships. Thank you.
Hi, I'm Lori Choma, and I'm from Calgary, Alberta. Congratulations on your amazing work. Thank you for your presentation. A lot of your stories today really resonated for me, and I'm sure for a lot of other folks in the room. You painted a picture of very high engagement with the practices and with the communities that you serve, and that you have a real shortage of resources. And so while we're not really flush with resources, we struggle on the engagement side and the uptake of the resources in a really meaningful way. An example of that is that we still really have those referral-based models with our team-based care. It's not that strong, true team-based care work yet. So the question that I have for you is, are you reaching scale with your projects? So when you talk about your opioid program and the engagement that you're getting from clinics, are you getting the spread with, and sorry, I missed how many practices you have in the region, but you're busy, which we feel really busy, but are you getting to scale with that? Are you getting to scale with your blood pressure, et cetera?
Good question. Can everybody hear me? There we go. I think the answer to that question varies. It depends on the project. And I think we all can relate to that, that sometimes what we aim to do is on a smaller scale. And again, thinking of some of this work that we do in the context of a research house, there are times when we're able to do something that engages just a small number of practices, because that's all we need. The It Matters study, for example, though, was a large-scale project. We have over 50 practices in the entire region, and our goal for that was to train 40, and we did that. And so we've had good success with engaging a high number of practices across projects like that. But I would say that that has come over time. That's not something that when the network started, for sure, certainly not when Christin started, that we would expect to go out and do. So I want to say yes, in some ways we are able to scale what we need to do, but as you can see, what that requires is somebody who covers a lot of territory, because so much of that is dependent on being present in the communities and having those relationships. I don't want to be all touchy-feely, but the relationships are so essential to what we do. So I think where the question comes in about scalability is, what do we do as an organization once we're done, funding goes away? How do we sustain that work? And that is a challenge, and I don't have a magic answer for that. One of the things, though, that we try to do in our infrastructure is to have a practice facilitator and liaison like Christin. We have other staff in the region as well, who just, again, by being part of this organization, are still there. They're not project specific. So if Christin were to go back to another project, to a practice on another project, she can touch base with them about, hey, how is your medication-assisted treatment coming along? And then we expect her to do that, even though that project may be long gone. So we try to both sustain, and then we do try to find ways to scale things to not just the network, but around the state or around the country. The home blood pressure program is a perfect example of that. We're actually in a position of, what do we do now? How do we take this to scale? So I hope that answered your question a little bit. Do you have anything you want to add? Okay.